episode 15, part 1, brought to you by Jessica Zeff, Simply Compliance, Elvan Baker, and Lorie Davis. Would you believe as I was walking the dog and trying to get myself organized for this episode, I gave you guys new names for reasons I have no idea. It was pre-coffee time. But just saying, just putting it out there. I love you ladies. But today, for those of you who are listening and don't want to hear about my dog walking experiences, today's episode is the first of a double whammy. We're going to be talking about United Healthcare and some of the issues and challenges that are surrounding United Healthcare at the moment. So why did we choose this topic? Why did we choose this topic? And why have we given it 2 episodes? Well, first of all, it's topical. Everyone, at least in the healthcare compliance space, is talking about United Healthcare and what's going on with this organization. It's also a very real life case study. It's not theoretical. A lot of what we talk about and the work that we do tends to be theoretical. We're trying to prevent maybe something from happening. And in this case, what we're seeing is the consequences. When that prevention, when those controls aren't in place, we're seeing right in front of us, some of the consequences. United Healthcare, the issues with United, it's also a great example of where compliance, quality, and patient safety intersect. We often talk about compliance as something that sits by itself, but the truth is, the reality of it is that compliance, patient safety, and quality, they all come together to give us this healthcare system. But we rarely see that. And United Healthcare and the issues facing the organization really give us a great opportunity to see that in play. It is a great case study from a compliance perspective. There's a lot to unpick with the organization and to study and to learn. And the case with United also speaks to the culture of an organization. What we're going to go through as we look at United Healthcare is that this issue of compliance or lack thereof is pervasive within the organization. There's a conversation to be had about the culture of the organization and what's really happening. And we get to see that in real time. Normally, a culture can be arguably intangible. It's not something that you can see very easily, right? But I think in this case, you get a very good perspective on what the culture of the organization is saying. And there's a lot to be learned from that. And before we go further, I do want to add a caveat. There are no politics in these episodes. In fact, when we record Compliance Deconstructed, it's not a political podcast. We are talking about things that are happening at the moment in the environment. The issues with United Healthcare, many of them started a long time ago. It's got nothing to do with anything particular happening in the current environment, political, economic, or otherwise. And many of the issues won't be resolved for a long time into the future. So I just wanted to present that caveat. We are just looking at this as a case study and a really great learning opportunity for ourselves and for anyone else listening into the podcast. So anything I said that's unusual or that you want to add to, Lorie, Elvan?
Oh, that's perfect. I think one little thing I was thinking last night about this episode, and because we're going to talk about so many different issues that come out of United, it's a giant corporation, guys. It's our job to pinpoint the problematic areas because that's a part of it. But please be mindful of the fact that United Healthcare is a giant organization. I've been an insured party for United, and I've had good experiences. I had bad experiences. So I don't want people to think that just because these subjects we're going to talk about that United Healthcare is bad, it just happens to be a big company. And as is with a lot of big companies, it holds a lot of different compliance groups within itself, addressing different issues or handling different parts of the compliance. So that's another, I think, part of for compliance professionals to be mindful, is that you might find yourself working for a big organization where you may be just one of the 200 compliance associates, but you still need to toe the line and do what's right and bring problematic areas forward, because one hand, and this is, we always joke about companies where right hand doesn't know what the left hand is doing. In big companies, it's not supposed to know that. They're supposed to be able to independently move from each other, but move in the same direction. So I think that's something that I just had in my mind thinking about, is just how big of a company it is, and how many hundreds of compliance associates that it houses, that are also hopefully doing the right thing, but still, nevertheless, we get these cases that the DOJ is, after.
No, but it's a really good point. If you think about the organization and the complexity, but how do you, again, that brings us as compliance professionals, how do you manage all of it? Like, how do you manage a compliance culture across such a vast organization with affiliates and subsidiaries? It's a challenge. It's not necessarily very easy.
I mean,
In fact, it's not. It's just not.
No. It's not humanly possible for one compliance officer to know everything, to be in the details, to move the train in the right direction. So it just depends on a lot of all the parts to move the way that it's supposed to move for things to happen. And when it doesn't happen, here we are. You get to have 2 episodes out of it.
So with all that said, and covering our bases, let's have a peek under the hood. Now, there are so many issues, keeping in mind what Elvan said about the complexity of this organization. We actually can't get to all of the issues in a lot of detail in 2 episodes, right? But let's have a recap of the issues so that we all get a sense of the scale of things, so that you really have a good perspective on what's going on. And once we do that, Elvan, Lorie, and we've chosen a few particular issues that we're going to take a deeper dive into and just explore what's going on there and what learning we can take away. All righty. So, United Healthcare, there are issues around the Medicare Advantage billing. So, United is under civil and criminal investigation by the Department of Justice over allegations of improper Medicare Advantage billing, specifically upcoding patient diagnoses to receive inflated federal payments, so additional money. And we'll talk a bit more about why that's so important, but there are issues around their billing. There's a case around antitrust and amnesis. To give you a little bit of a summary of what that is like, looking at my notes because it's fascinating. So the key antitrust legal issues is that United Health bought a home health provider called Amnesis, which had already acquired a rival group. So the government is saying, hold up, wait a minute. By United Health purchasing Amnesis, this is a merger that would affect that would result in unfair competition. So United also has this antitrust case that it's working through. There's a lot of state consumer enforcement action in the state of Massachusetts. We'll have a look at that a little bit later. There are cases around denial of claims. So United Healthcare has been taken to court on several occasions because there are allegations that United Health is unfairly denying claims. And we're going to have a really deep dive around that. Even when there's medical necessity, patients aren't getting the care that they necessarily need or that they should be getting. There's also controversy around insulin prices, and an allegation that United Healthcare, along with some other organizations, have been inflating insulin prices. There's a case around, there's a lot of controversy, as I'm sure many people already know about, involving prior authorizations, where the allegation is United Healthcare is using prior authorizations to deny care, slow down care unnecessarily, and it's been having a particularly adverse effect on its members and the people who need the care. There's also a case from the TCPA around unfair marketing practices and robocalls that are being made to people without their consent. So there's really a lot going on in all kinds of different parts of the organization. Though, of course, there was also the data breach with Change Healthcare, which really affected and is part of United. So, with all of that said,
are we going to play a game somewhere along the line? And what do we think? I just thought about it. Can we guess not the outside counsel they retain for these, but what do we think the size of their in-house litigation unit?
Oh, millions. It's got
No,
to be
but by
millions.
head count, by head count.
Oh, by head count? I
By
don't
head
know.
count. How
It'll
many
be
people?
a lot of external.
Because
I
I'm
bet it's
thinking there's a poor guy at the courthouse consistently standing there, and somebody keeps handing him a new folder.
Well, and there's more. Like, there are two other ones that I forgot to mention. There's proton radiation. There's a whole controversy about proton radiation and United Healthcare denying it as treatment for prostate cancer. But and they're saying that it's experimental and investigational, but actually it's not. And United agreed to a $9.5 million settlement to address this issue because a lot of very sick patients didn't get the treatment that they needed. And there's another interesting case with United Healthcare around ERISA. And for whatever reason, United Healthcare, I guess they did something with their 401k funds and they're not able to pay it out for their employees. We can talk about that a little bit more and get into the details if we have time. But I mean, that's what I meant when I said the issues were pervasive, and it must be a cultural issue. And I get that it's a huge organization and very complex, but there's something else going on here. We have other complex organizations, big organizations, and it could be that they're just hiding it well, but we're not seeing necessarily these kinds of large scale issues across everywhere. Would you guys agree? Okay.
Yeah.
Lorie?
Yeah, so far so good.
This is all Lorie's homework, by the way. She did the homework and is keeping me and Elvan. I mean, we've been itching to talk about this anyway, but she got the full comprehensive list. And even Elvan and I were going, what? We're a little surprised because more keeps coming up. So between our initial idea of talking about United Healthcare and actually getting to this podcast, there's more that's come out of the blue. So let's do that deeper dive and let's look at the Medicare Advantage billing and what's going on there. So, there's this allegation by the Department of Justice that United Healthcare is billing Medicare improperly. So what they're doing is they're trying to, I don't know how many of you know, but in healthcare, the way that insurers and payers get paid from the government for Medicare and Medicaid, commercial insurance as well, is by using codes. And each code denotes a treatment or a medication or a something. That's how it works. Now, there's something called upcoding, where you can say that a patient is sicker than they are so that you can give them more treatment codes and then attract more payment, right? More revenue for that patient. That's considered fraud. If the patient is really sick and they're being treated, okay, fine, that's one thing. But if you're looking at a particular set of diagnoses and you're trying to say, oh, well, the patient is sicker than they really are, that's fraud. So essentially, United Healthcare is being accused of committing fraud. So the federal government, we talked about that. So the case was brought by federal investigators and whistleblowers, and they're alleging that United Healthcare inflated these codes,
Mhm.
by upcoding. So the company was recording diagnoses that make patients appear sicker than they actually are. There were in-home assessments where the Health and Human Services Office of the Inspector General raised concerns that diagnosis from in-home health risk assessments that were conducted by United Health employed clinicians were
Mhm.
used to boost payments without evidence that patients received treatment for those specific conditions. So it's not just people sitting in an office, it's not just something that
Mhm.
happened by accident. There's something going on about the culture of the organization, that staff or employees were sent
Mhm.
into people's homes to do assessments and do this upcoding. The Department of Justice also interviewed a number of United Health clinicians who claim they were pressured to add diagnoses without proper supporting evidence, such as lab tests. And the other issue is that United Health is facing a class action lawsuit allegedly for using an AI driven algorithm to systematically deny claims for post acute care, prematurely forcing patients out of nursing homes and other facilities, while allegedly at the same time underpaying in network providers for care that they gave.
This is quite crazy, actually. They're doing upcoding on one end to get more revenue, and they are basically downcoding a patient that is still sick to get him out of the nursing pay so that as to not pay out that much more.
Yeah, this is absolutely crazy. And there's a DOJ investigation, civil and criminal. There's also a whistleblower lawsuit ongoing around this particular issue. And also the provider that was underpaid and had their claims denied inappropriately, they're also suing United Healthcare.
Okay.
So going back to your question about the legal support, I honestly dread to think. And one of the things I think a number of things, right? Like, first of all, with all the information around fraud and all the guidance that we're given and all the information that we have about not upcoding, about, medical necessity, about documentation, about having the evidence to support billing, I can't understand why on earth anyone would have been instructed or allowed to go ahead and engage in these practices. You must understand, or maybe you don't understand, the risk that a regulator or somebody is going to come after you. And these practices are going to come to light eventually. And they're going to be so much more expensive. I don't understand how United Health, in this case, where was the profit? They must have understood the risk at some point. One assumes, I would think, they're not living in a vacuum. It's a huge organization with all these different parts. Somebody must have understood the risks of these activities. And they didn't think it might be more expensive in the long run to do things the way that they did than to do them properly in the first place. Like, I don't get it. Where's my faulty thinking? Like, what am I
It's
missing?
not the beauty of criminal intent. It lives in its lack of forethought. If all criminals thought that they were gonna be locked up in jail one day, they wouldn't. Go ahead,
So,
Laurie.
on the other hand, I wonder if when discussions are had, there were misinterpretations, like they thought they were giving guidance. On the other hand, what I was thinking is, could this have been a situation where the provider heard something? Generally speaking, on the health plan side of the world, you don't tell providers how to bill. The state gives you fee schedules where it says, hey, for these services, you can use codes XYZ. So is it possible that there was just a gross misinterpretation? Like United said, we will pay these codes for these services, and the providers took that to mean, oh, we should bill for these services. I don't know. Obviously, we weren't there We don't know. We don't know what the claim submission looked like, whether it was a HCFA or UV. So I really think that there could have been some misinterpretation, because generally speaking, on the health plan side of the world, you don't tell providers how to bill. You will reject claims or deny claims and say, hey, you need to go look at this again. At least in my experience, I don't know, Elvan, Jessica, about your experience, but in my experience, you don't tell providers directly how to bill. So
Mm.
I wonder, that's something I've been wondering about, is how did we get here? And that's my big thing, is that I hear in the back of my head every claims director, every provider director I've ever worked with saying things like, well, we don't tell you how to bill. We don't.
Yeah, I'm thinking, yes, we don't tell the clinicians what to code for sure, but there are very, very many ways that you can systematically course or convince a clinicians to bill. For example, on the home health case. For home health agencies, what happens is that as a clinician, you go out to the patient's house and you usually have an electronic device that houses your OASIS assessment, and they sit down and do the assessment with the patient in front of them on the spot right there. They enter the diagnosis. Sometimes if there's a caregiver, they do, balancing of the medication, diagnosis codes, and all of that. And then they submit this to their home health agency. At the home health agency, they have an OASIS certified reviewer. And that person will call that clinician. I know that this happens all the time, and say, hey, you entered, okay, they will say, I'll give a very good example. And this is a part of convincing. Sometimes it works for the better, sometimes it's not. You entered Alzheimer's disease, late stage. You entered XYZ. How come memory loss is not coded then? You can't have those two without having this third. That third may become a part of upcoding, though, when combined
Like a
with these
service
two.
verification, but that's a service verification, right?
Not
They do
necessarily.
it.
That's the code that they would say to the clinician. You reasonably, it's like saying a person who's double amputee does not have any hard of walking.
Mhm.
Like, so they
Okay.
will make a recommendation to the clinician. The clinician kind of feels, I guess, okay, you're a part of the home health agency management group. You're right. They will reason with them. They will add the code unbeknownst to the clinician. Now combine those three codes, combined with each other, become a systematic upcoding, road. I mean, so yeah, they don't tell clinicians how to code, but surely there are a lot of ways to convince a clinician to code a certain way.
And there are other things going on. I mean, what you've
And I
both
think this is all systematic,
suggested-
right? I mean, we're not saying one-off instances where a manager is trying to teach a clinician, what the DOJ is saying.
That's all right. But what you're both suggesting, and that really worries me, and you've both, I mean, that was a really good example, both of you, of what I'm going to say. Where are the controls? I would have expected the controls to be in place to pick up somewhere at some point, to have picked up some of these issues. Now, it's possible that some controls fail. Okay, there are many reasons for that. I get it. But there should have been something that flagged, hey, is there something going on here? Why isn't this? What's going on? It's not working. And I don't see any of those controls. I don't see them from United Health. I don't necessarily see them from the sub organizations involved. I don't necessarily see it from the government either. Like, was no one picking up on any of this activity? Nothing somewhere. Eventually they did, but United Healthcare was able to get so far. And I don't, maybe it's because I don't know enough of the details, but I don't understand how they got there. And that's what I was going to say around controls. And I was going to say something else, but it left my head already. But those are really good examples.
I mean, how does it not get caught? It was probably caught, but until they could prove that there was a systematic action, then they none of this came out. So,
well, the other thing is, I wonder when we're talking about home care, and I'm thinking about the trust case,
mhm.
is there something to be said about the risks of a health plan owning its providers? And how do
Huge.
you handle that risk? I mean, it seems to me that, if you have a health system or a health plan that owns its providers, there's an opportunity there to maybe unduly influence.
Mhm.
And there's also a lack of maybe transparency or external oversight because now everything is kind of almost under one umbrella. I would argue that imposes additional risks, and that kind of organizational structure needs to be examined quite carefully
Mhm.
to make sure the right infrastructure and the right controls are in place to flag potential conflicts.
Mhm.
Yeah, definitely you need to make sure there's a firewall of some sort in place so that you're not unintentionally sharing information between the two sides so that the controls do hold. I think, Jessica, that's where I hear you and get concerned. If they're managing that network, how are you balancing to make sure that information isn't getting unduly shared inappropriately?
Do you have any thoughts about how that happens? It's okay if you don't, but any
Uh,
ideas?
I think there could be situations where, for example, provider sits within the health plan as a chief medical officer or one of the medical directors for a specialty, because depending on what kind of plan you want to have providers on staff that can provide peer-to-peer support to give oversight to your clinicians, that sort of thing.
Mhm.
So I think sometimes it could have started very innocently, where you had a doctor on staff who thought they were sharing information with good intentions. And again, it got twisted or misinterpreted or something like that. That's the scenario that my head goes to. I don't know about
Mm.
Elvan.
I wasn't thinking about any of this when this is this is what makes the podcast fun because I'm like, I that did not even come close anywhere near. I was thinking in my head when Jessica was talking about, okay, is this really appropriate for these entities to monopolize so many different parts of the system?
Mhm.
That's I was thinking that, and immediately a good example, it works out well when the intentions are good. It really is a detriment to the patient's well-being when it is used to only to uphold the financial well-being of the entity. A good example here is actually I don't want to go. I was going to give an example from TRICARE, something I had an experience, but I'll go with another local example here. Here we have a local rural hospital system that is growing very well. Now it owns most, not all, but most of the physician offices, specialties, clinics. They've grown. Perfect. And they're one of the largest employers also where we live. So they insure
Yes.
their own people, they have their own insurance plan, they all have their own pharmacy, own providers taking care of each other. Basically, it's its own ecosystem, right? It works out beautifully because they have no in on not taking care of the patient, because if that patient is not taken care of, who's also probably their employee, is going to cost them more in later, right? So they really fight for more efficient, more cost saving solutions. They really work hard to give the right amount of care to the patient, because patient is a part of their own team within the ecosystem. That works out great when that's the case. And of course, God help the person who would have to go make an argument, because when all entities are a part of one, they're going to look out for each other. So it's really hard to fight within it, right? So never had that experience. I can imagine that would be really hard. But in instances, let's say that you have an elderly person in the United Healthcare situation, and I'm just going to adjust just to give a right example, but let's say that the patient who is an elderly patient who's insured by United Healthcare, and they're going to go to, they fell, broke their hip, they're at the hospital. Let's assume that United owns the hospital. They rule when they discharge. And then let's assume that they go to a United Healthcare owned and operated subacute care. Just in this case, they tell you when you're fine, not you. You go back home when they say you're ready to discharge. Now you go back home. Their home health agency comes to take care of you. And, within the system, they keep telling you when and how, as a human, you're operating. I guess I'm having a hard time explaining. Instead of you having some amount of autonomy in your care. Because then they say, okay, once a patient X reaches this level of independence, I don't want to pay any more of nightly rate. They go back home. They go home, they're kind of okay. And then the home health agency comes and says, you know what? You're not as good as we thought you were. So we're going to order more labs. And now we're putting these diagnoses on you and we're going to charge this. So it just you become a pawn in the system almost.
But that's
I
a
don't know if
really
I
great
gave the right
example. No,
example.
you did. You did. That's a super example because it really illustrates that point very concretely about what could be happening
Mhm.
and about how quality, patient safety, and compliance all wrap up
Mhm.
into, the outcome of patient care. I thought that was a stunning example. And
And you lose
what I didn't
autonomy as a patient, and you lose the ability to say, because they need to be just those firewalls that Lorie was talking about. We need those as patients to be able to say, hey, time out, time out, time out. I'm able to find a better price of X here. But if that ability is taken from you, who are you fighting for and with whom?
Well, also, it means the guardrails that need to be in place between different parts of the organization might not be as robust as they need to be. And something, Lorie, I never thought about it in the way that you explained. And I think that's fantastic. Elvan's right about the podcast. We're always learning from each other, but I never thought about the tension of needing to have maybe provider representatives within the health plan. And that can be a really difficult relationship to navigate, right? There's always that kind of tension between having providers involved to give input and understand what's going on, but also not having them be co opted. They have to be comfortable enough to raise a challenge, to lead. And
Mhm.
I wonder, that must be an awfully difficult line to follow or to walk. And I never
Yeah.
considered that.
Mm. I often, I've been fortunate to interact with a lot of great medical directors in my time. And I always, when I listen to them during appeals hearings or
Mhm.
grievances, how seriously they take it, and overwhelmingly how much they advocate on behalf of the member. It's not that they automatically take a provider's side. They truly want to hear both sides. I have been very fortunate. Sometimes I'm sure there are providers who advocate on behalf of providers and not on behalf of members. But my experience is overwhelmingly medical directors think about the well-being of the members first, and then provider needs come second.
Mhm.
But there is a balancing act. So again, I'm trying to take this view of what could have happened and how it could have been. When I think
Mhm.
non-healthcare for just a moment, I think of United Healthcare like Tyco. Do you all remember Tyco International? It was huge. They had 6 different branches, and
Mhm.
they literally were on every continent except for Antarctica, and I think they were thinking about going there.
Oh, wow.
They were huge, 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 huge global company, and they literally would have groups that would come together across the entities to try and work together to make sure that things were being done the most appropriate.
Yeah.
And then things went horribly wrong. as things are wont to do when you've got that many entities and that many people.
The
And so they
natural.
had, yeah, so they had to break up. And I'm wondering here if United, I know at the legislative level, at the federal level, they are making that advocacy to break up United because they are so large.
Yeah, the sheer complexity of the organization and size may naturally make it quite a
Mhm.
challenge to manage the organization. The other thing, though, I know you're talking about medical directors. I think part of
Yeah.
the issue was that the allegation is United Healthcare was using an AI algorithm to
Mhm.
override the doctors and the medical necessity determinations by the folks who were treating the patients. And that was part of the problem as well. So again, coming back to your point, you might have had medical directors and clinicians making solid decisions. And for whatever reason, the organization itself decided they were going to take another route.
Yeah. The other thing that I think about is the type of business this is. So a lot of these claims are in the government owned space, so Medicare,
Mhm.
Medicaid. And so there are additional guardrails in place that I think we need to make sure we're thinking about. And somehow I also want to believe that this would have come out in a government related audit, whether that's a RADV, a 1/3 financial, a program audit, an external quality review, or an ECRO, an internal systems capability assessment, or an ISCA, or something to that nature, where I think once they got to these audit years, I believe that's why this is coming out now, is because they finally got audited. Not
But
sure
that's
how
the
you all
thing.
feel.
That's the thing. When we were talking earlier about controls, I think that's one of the things that most upsets me because we, as compliance professionals working in this field, we know we're going to get audited, or that's certainly, the story that we tell to ourselves and to others.
Mhm.
And in most cases, that's happening, right? And I'm just a little confused, I suppose, and more than confused. I'm a little angry. All those regulators, why weren't these issues flagged sooner? Or were they? And it just took a long time to work
Yeah,
through. But some of these are so pervasive and so big.
Mhm.
Was United just too big to fail? Like, what happened?
because I've given it so much thought since we talked about this, Jessica, about why did this show up in claims, I really do think it's because of the random sampling nature of most external audits that it took time for it to show up. And then once it did, they pulled the proverbial thread and said, we have something. Let's start digging deeper. That's kind of my thoughtful consideration after having some time to actually think about it.
I think it's a really great point. I mean, I got angry because I felt that, we work in this space. Well, but
Uh-huh.
we've all been patients. We
Mhm.
have people that we love.
Yeah.
It's not that
Correct,
we,
correct,
on a
correct.
professional and a personal level, we
No.
actually, we
Mhm.
empathize, right, with what's
Yeah,
going on. And
absolutely.
even as a taxpayer, I thought to myself, well, where are these regulators? This is what they're there to do. So I even though I hear, what you're saying, part of me is still quite angry. I feel that something somewhere failed, not just United, but somewhere our regulatory systems, our auditors, and I might be wrong in this. This is just my perception of it. I'm one
Mhm.
person, but I
Yeah.
feel that something else failed. It was a systematic failure way beyond United Healthcare. And I do wonder, is United just so big? Did things just take so much time to percolate? I don't know. I I don't know.
Oh,
I
it's
don't
not.
have an
We don't
answer.
even know if it percolated for them to fix it. Had they fixed it, they.
No, but even within the regulators, I know
Mhm.
that you get time, say there's an audit, there are
Mhm.
findings, you get time to address them. They come in, they
Mhm.
audit you
True.
again. It might be a year later. and then they still have findings. They might give you another opportunity, another year goes by, and before that you've got 2 or 3 years before these issues. But in the meantime, people may be suffering, and also the organization itself is accumulating almost like a bad debt. Because eventually they're going to have to correct it, pay for it, but it's not being addressed.
But I
It's been
thought
going
that
on
they
since
signed,
2017.
I think they signed a corporate integrity agreement, didn't they? So if they signed a CIA, they were essentially making efforts to make sure that things were remediated.
You know, just because United Healthcare signed it doesn't mean they actually did anything.
Correct.
I mean, she's saying, you know, it shows a commitment. Well, CIA is a piece of paper. It is a legal quasi-legal document. But nonetheless, you can sign anything you want. Whether you actually go and do anything about it is something else. And at the end of the day, they must have signed these corporate integrity agreements, but it wasn't sufficient to prevent all of the actions that are coming out of this organization and this investigation. So that leads me to believe, because we're having these episodes and there's so much, it leads me to believe that the organization really wasn't learning or adapting to whatever was going on in those corporate integrity agreements, because some of these issues are the same again and again. So whatever it was, it wasn't working. All righty, folks, we've had a really great look under the hood for the Medicare Advantage billing piece. That's been controversies that have been going on with United Healthcare. We're going to give it a pause. Oh, Elvan, did you want to say something? You look like you're about to say something. Okay. So we're going to give it a pause for today because that's a lot of really great information and a great discussion. There's still a lot that Elvan, Lorie, and I want to cover about this case. So you know what? You're going to have to wait till episode part 2. I know you can't wait. But thank you for joining us. Hope you found the conversation to be interesting and relevant. We certainly had fun, ladies, right? We've been dying to do this episode.
Absolutely. Good discussion.
So hopefully we'll see you guys and you'll tune in to the second part of our exploration of United Healthcare. All right, everyone, take care. See you next time.